Good afternoon, everyone. I'm Dr. Vamsi Krishna, consultant neonatologist and pediatrician KIMS Cuddles Kondapur. So nowadays we are using ultrasound machine in our NSUs for various purposes, like doing the point of care echocardiography, neurosonogram, and for putting the lines, central lines. So also we are using much ultrasound for the assessment of the lung status and other pathologies of the lung. So it's worthwhile for discussing the basics of the lung ultrasound. So today we'll briefly discuss what is the lung ultrasound and what are the different kind of findings that we'll get by using the lung ultrasound. So as we know that lung disorder one of the most common cause of problems in the newborn period, that most of them may be life-threatening for both the term and the preterm newborns. We need an accurate and rapid diagnosis of this lung disease because diagnosis of each disease will lead to the specific strategical management of the condition, and so we can have a diagnosis based management of each condition. So for this purpose, we have an X-ray. So we are using the X-rays for a predominant period of times, and majority of the symptoms are taking care of the newborns predominantly on the X-rays. However, there are certain problems with the X-rays that we need a specific examination, we need a technician, we need to have the film to get printed, and by the time all these things, we can have a point of delay can happen before we can diagnose the condition and treat the baby. So nowadays we can use the lung ultrasonography, an adjuvant, or in fact we can replace sometimes the X-ray so that we can use for better purpose of the management of the units. And it's also helpful for differentiate different kind of the lung disease so that we can tailor-made our the management. And the advantage with lung ultrasonography, it is radiation free and it is very convenient to use. It's much high accuracy and it's very low cost. In fact, we doesn't need to have any other accessories except the lung ultrasound machine and the probes. And it is very easy to operate if we are adequately trained. So in this way, it is very promisable bedside tool for the assessment of the lung status and the identification of the pathologies. So basically, in compared to the ultrasound of various other organs, the lung ultrasound is not the exact depict of the anatomy of the particular structure. Like when you're doing the ultrasound of the brain, we'll see the what is the status of the structure of the brain and we can identify the abnormalities. However, in lung ultrasound, we are not actually seeing the normal anatomy of the lung because the ultrasound waves have been reflected by the air that is present in the lung. So what all we are seeing is actually the artifacts. So the lung ultrasonography is actually the display of the number of artifacts. And when these artifacts are present, and they along with other artifacts, they create a specific pattern, which is more specific to a specific lung condition. In this way, by identifying the different patterns, we can interpret what is the underlying lung condition the neonate is having. So as we discussed, ultrasound is limited in the normal aerated lungs because no acoustic mismatch occurs in the ultrasound beam when it encounters air. The air will not reflect, the air will not transmit the ultrasound waves. It just only the reflect the waves back so that this reflected waves will create a pattern. So once you have a machine, we need a specific probe. So we want a high frequency linear probe with having a small footprint. So one of the best things that we can use a hockey stick probe, or we can use a linear probe, which is having highest frequency. So on average, we can use around 8 to 15 megahertz frequency. So any frequency at least 9 and more than 9 will be a good probe that we can have a good visualization of this lung ultrasound. So when high frequency probe is used for a better resolution, so any infant who is born at lower gestation age around 24, 28 weeks or having very low birth weight, or especially the ELBW and VLBW base, we need a very high frequency probe, which they doesn't need to have a great penetration. We want a superficial penetration that can give a better picture. In the babies who are bigger infants and higher birth weight, we can use a bit lower frequency probe where we need more penetration of the waves is needed. So the hockey stick probe is currently the one of the most useful probe for doing the lung ultrasound because it is a high frequency probe and it is a very good kind of the footprint. So which by placing on the chest, we can have a good visualization of the underlying lung condition. So the next is what kind of the plane that you want to use for the lung ultrasonography. So one, we can have a perpendicular vertical plane as depicted in the picture. So where we'll, and second thing is a parallel or horizontal, which we rarely use. So in majority of the places on condition, we require the perpendicular or the vertical plane. So we are discussing on this plane only. So in the perpendicular or vertical plane, we place the transducer along the longitudinal line, in a way such that it is perpendicular to the chest wall. So it will be perpendicular to the pleural lung surface, and we keep the probe in the midline, and then we'll move from the midline to the lateral. So in this way, we will do the lung ultrasonography with the specific probe in a specific perpendicular plane. So for convenience, we'll divide the lung into three regions. One is an anterior, one is a lateral, and third is a posterior. So the boundaries between this thing are the anterior and the anterior axillary line, the posterior axillary line as boundaries. So anything that is present anterior to this anterior axillary is anterior, and between the anterior and posterior axillary line is your lateral, and the thing that is present behind the posterior axillary line is your posterior thing. So in this way, each lung can be divided into the three regions, and each region is again divided into the another half areas. So overall, we have a 6 regions in each lung. So we have a total of 12 regions in both the lungs. In this way, we can partition the lung. So because we'll be managing premature babies and the neonatal babies, the prevention of sepsis is most important. So we need to disinfect the probe in order to prevent the nosocomial infection, cross infection before utilizing on any baby. And for the lung ultrasound to have a good picturization, the neonate should be quiet and should not move much. And also we should not move the probe too fastly, and we should not again give any movement to the probe, so that the lung ultrasound picture comes in the way that we want. And we need to examine the baby in supine position for the anterior regions and lateral position for the lateral regions. And we sometimes need to keep the babies in the prone in order to examine the posterior part of the lung ultrasound regions. So coming to the anatomical landmarks. So in the picture, as we can see, so this is usually there's the skin and the subcutaneous tissues, and there is a pectoralis muscle. Then we'll have the ribs with intercostal muscle, and below this we have a pleural lines, and below this is the lung is there. So in this way, here also we can see there's a chest wall subcutaneous tissue. Then there is a muscle is there. Then we have the ribs, and this is the intercostal muscle. We have the parietal pleura. There is a visceral pleura, and usually there will be small amount of very minute fluid will be there, and no air in between the parietal and visceral pleura, and below this there is a lung. So these are the anatomical landmarks. So of these, the most important is we need to see the ribs, and we need to identify this pleura. So this ultrasonographic picture of the lung ultrasound, where we can identify these are the ribs, and this is the parietal pleura. In the similar way, we can here see these are the ribs, these are the ribs, and here also there is ribs, and this is the pleura. So this is the called as a bat sign, where your ribs will be appearing like the wings of the bat, and this is the body of the bat. So when you see this kind of the picture, we in the lung ultrasonography, this usually depicts a normal thing, and this is called as the bat sign. So the appearance of the bat sign is the normal in the case of a lung ultrasound. So the other normal lung ultrasound patterns are, we need to see the A lines, pleural lines, and the pleural sliding, and we need the occasional single B lines artifacts and the comet tail trend. So one of the most important normal lung pattern is the A lines. So the A lines are actually the reverberation artifacts that are caused by the multiple reflection of the pleura when you keep the probe in a perpendicular to the ribs. So here we can see this is a pleura, and these are all the A lines. So these are the reverberation artifacts. So we can see that these are very smooth, clear, regular, and are equidistant. The distance between the pleura and the first A line and subsequent lines will be equal. And as we can see that when the lines move from the superficial to the deeper, so the A line slowly fades. So this is the A lines. So the normal lung usually have the A lines, and these are the reverberation artifacts that are coming from the pleura. So next, which is a pleural line. So this is the pleural line. So the pleural line is usually the hyperechoic reflection that is formed because of the acoustic impedance between the pleural and the lung surfaces. So usually it appears as very hyperechoic, smooth, regular, and straight hyperechoic lines. So if you find any blurring of this pleural line, any irregularities, or any breakdown of the continuity, or sometimes there may not be any pleural line visible, this usually indicates there is some abnormalities in the lung. So the next thing is pleural sliding. So normally when you breathe this, so the parietal pleura will be moving against the visceral pleura, and we can see that there is some kind of a lung that is getting sliding every time we breathe, we take the breath. So this phenomenon usually appears as shimmering line, and this is a sign of a healthy lung. So normal healthy lung will have a pleural sliding. So whenever there is an absence of pleural siding, so there might be some kind of an air that inhibit this normal movement of the basal parietal pleura. So in this video, we can see that the pleural line is actually moving as the baby is breathing. So in this way, the pleural line is moving. So appearance of a pleural sliding is usually suggestive of a normal lung. So the next is a seashore sign. So when you put a M mode in your ultrasonography machine, so over the pleura, so usually we can see this kind of the pattern. So this is called as a seashore sign. So where you can see that there is a sea and small grains like of things that usually seen at the kind of the uh, at the beach side. So where you can see small this kind of a granules that are appearing. So this is called a seashore sign. This is a normal sign. Then sometimes there can be B lines that are present in the newborn. So the B lines are a vertical laser kind of lines, which are hyperechoic lines. So they arise from the pleura and extend all the way to the edge of the screen. So usually the B lines can be seen in the initial 24 to 48 hours in the newborn babies. And because it usually represents the presence of some amount of fluid, which is common in any newborn, there will be the lungs are filled with the water in the initial period of time. And when the baby cries, when the baby breathes, there's absorption of this lung fluid. So initial around 24 to 48 hours, there can be this kind of a simple B lines are present. So in order to label the simple B lines, they should be just like a vertical laser-like lines, and your A lines should be still visible in the B lines. And B lines usually are counted in the two adjacent rib spaces. So these are rib space, these are rib space. So usually in between the two, between these three ribs, we usually see this kind of the line. So usually the number of B lines should be less than 3 in the two adjacent rib spaces, then it is called as normal. And if your A lines are also visible, then it is called normal. Sometimes the B lines may not may not extend till the edge of the screen. They just present this like a common tail signs. This is also normal. The simple B line is a laser-like hyperechoic white lines extend from the pleural surface till the edge of the screen, and it usually have A lines in the B lines, and the A lines are not completely erased. And when you count the B lines in two adjacent rib spaces, that is between three ribs, if the number is less than 3, the B lines is occurrence of B lines is normal. And the comprehension of a common tail is also normal. So what are the abnormal lung patterns? So the appearance of simple B lines is normal as we discussed. This can be seen in healthy newborn babies. However, they should be like just like vertical lines, and they should not be compact, and they should not be numerous. So less than 3 is normal. And they usually present more often on the right side. And as we discussed, B lines are because of the fluid in the interstitium of the lungs. And also whenever the fluid is there will be decreased aeration. So when you have the more fluid, the more B lines. So small amount of the fluid will be there in any newborn baby. So this is common. So appearance of simple B lines is normal. If you have more fluid, if you have more amount of edema, then there might be more wide compact B lines. That is not normal. So the abnormal B lines include the confluent B lines. So the confluent B lines is where the entire intercostal space, so entire the pleural reflection, there will be a solid B lines and the A lines are not visible. So previously we have seen a simple B lines where we have just like a laser-like thing. So this is the intercostal space. So the intercostal space previously we have seen there is just like a 1, 2, 3 lines have been seen. So now we are seeing in this confluent B lines where the entire intercostal space is as a solid white B lines. We cannot see any laser-like things. So the entire intercostal space is completely a solid white lines. And we don't see any A lines. So confluent B line is the one where the entire intercostal space is filled with solid B lines and the A lines are not visible. So that we call as a confluent B lines. The next term is alveolar-interstitial syndrome. So we label as the picture as alveolar-interstitial syndrome when we see 2 or more confluent B lines in any scanning area. Suppose if you put a hockey stick probe on the lung. So in that scanning area, if you see 2 or more sequential confluent B lines, then we label it as a alveolar-interstitial syndrome. So here we are able to see this is 1, this is 2, and this is 3. So in this scanning area, also we are seeing 4. So more than 2 confluent B lines. Confluent B lines is again, I'm telling that this is a solid Y lines without any A lines. So here 1, 2, 3, 4 confluent B lines are there. So it's more than or equal to 2, then usually it is suggestive of alveolar-interstitial syndrome. So normal A pattern is where we have a pleura with reverberation of only the A lines without any B lines. Then we have a small space, simple B lines. If the fluid is more, then we can get this confluent B lines where the solid B lines are there. And then if you have more amount of two or more the B lines, then it is called as alveolar-interstitial pattern. So in this way, the lung appearance when there is no fluid, some fluid, more fluid, and very more fluid or edema is there, then we can see this kind of the alveolar-interstitial symptoms. Also here we are also able to see there is some amount of subpleural consolidation. That we'll be discussing what is this in the next slides. So if you have lungs is having more amount of compact B lines in 6 areas, then without any A lines, then we call it a white lung. 2 or more compact B lines, because alveolar-interstitial syndrome, we have a 6 B lines without any horizontal, where we are completely looking this like a white out lung. This is called as a white lung. Then we can sometimes see this kind of picture. This is called as lung consolidation. The lung consolidation where the areas, the solid areas with irregularly defined borders will appear as a tissue-like density similar to a lung, looking like a liver. So this we call this as lung tissue hepatization is happening. So when you see these lines where they have B lines, here we can see that very irregular lines that is associated with dense tissues, like you can see the liver and the lungs are looking like almost similar thing. And this lung consolidation may have some amount of fluid, may have some amount of air, which can lead to small amount of speckle kind of things. And we can see that the pleural line that is the present above to this kind of consolidation is not there, is disrupted. So this we call as consolidation. So in a consolidation, there appears a solid area similar to the liver, but called hepatization of the lung, and we have a irregular, poorly defined borders, and it can have air and fluid, and the pleura that is present over the corresponding area is either abnormal or completely get disrupted. So then we can see this kind of picture is a lung point where usually happen in a case of a pneumothorax, where what we've seen is when you put a probe, there will be an area where your lung sliding will be present. There will be an area where your lung sliding will be present, and there will be an area where your lung sliding is absent. So this kind of the point where there's a transition from a normal lung sliding to the abnormal lung sliding, that is the area where we call this a lung point and usually specific to the pneumothorax. So here you can see that this might be the normal lung without a pneumothorax, which also has the B lines. So this is normal lung point, and here this is a normal lung, and here we have an area where you don't have any B lines. We are looking like only some kind of A lines are there. So this transition lane is called lung point. The lung point is highly suggestive of pneumothorax. Then we have a double lung point. So double lung point is again a short cutoff point between the upper and the lower field on a perpendicular scan. So when you put a probe in on a perpendicular plane, so the upper part of the lung may have a good aeration without any fluid, which appears as a normal point, normal A lines. And the lower part of the lung where there can be some amount of or more amount of fluid, which can be present as a confluent B line. So this sharp cutoff point between this normal lung and this confluent B lines happening is called as a double lung point. The double lung point usually suggestive of TTN. We can have a doubt how to differentiate between a single lung point and double lung point. And normally in the double lung point, the pleural sliding is present in both the areas. In a single lung point, in a lung point, the part where we have the pneumothorax, where the lung sliding will be absent, that may have a normal A lines, and the point where we have a B lines and the normal lung sliding will be present. So in the double lung point, the lung sliding is present in both the areas. In a lung point, the lung sliding is absent in one area where there is pneumothorax, and the lung sliding is present in the area where there is no pneumothorax. So in this way, we can differentiate the lung point and double lung point. So then we can have this kind of picture when there is an atelectasis of the lung, where you can have this kind of consolidation areas with small amount of air, which appears as a very white dots like stars kind of things in this area. So this is called as atelectasis. So atelectasis areas of consolidation, which contain small air trapped bronchograms, which appears as a stars in the sky. In contrast to the consolidation in pneumonia, there will be an regular and the clear edges. So you might have seen in the previous way there is irregular edges. So we can see this kind of area where there are the regular edges, and there appear as a stars kind of thing because of the air bronchograms. And the pleural lining abnormalities can happen here also. in this way, we can identify the atelectasis. So small atelectasis that usually happens might not get picked up in X-rays. So in this way, we can identify the atelectasis and we can provide optimal PEEP and the physiotherapy so that we can chest physiotherapy, so we can open these small lung areas, and so that the baby can improve. So in this way, identification of the small atelectasis, we can use the lung ultrasound. Sometimes we might have seen the babies who might be requiring small amount of the oxygen, a small amount of support. When you've seen the chest X-ray, the chest X might be normal. So when you do the lung ultrasound, if you find this kind of the pattern, we can diagnose there is a small amount of atelectasis present. So we need to provide adequate amount of pressures, and we need to do the chest physiotherapy. This can will open up and slowly the baby will get weaned off from the respiratory support. In this way, atelectasis diagnosis can be helpful in the management of the babies. So once we have understood the normal lung patterns and abnormal lung patterns, we now combine these lung patterns and we can identify the specific lung conditions so that we can manage the babies very early, even before the findings on the X-ray can appear. So one of the most common cause for the distress in the newborn respiratory distress syndrome because of surfactant deficiencies. So where your alveoli get collapsed, filled with fluid, and maybe some amount of consolidation and bronchograms can be seen on the X-rays. So similar to them, in a case of a lung ultrasound, we can see this areas of consolidations, and there can be some amount of air bronchograms will be there. In a RDS, there won't be any A lines. The pleura will be usually thickened, and there will be subpleural consolidations usually seen. And if you don't have any consolidation kind of thing, they can just appear as alveolar-interstitial syndrome with confluent B lines. And we can also see 15 to 20% babies, the respiratory distress syndrome babies may also have an unilateral or the bilateral pleural effusion. So here we can see the lung ultrasound of an RDS babies, where we can see the pleura. We can see that is more of a thickening of the pleura. It is happening more hyperechoic regions, and there is a diffuse confluent B lines are there. So, and the another pattern is where we can see again the pleural thickening, and there is some amount of subpleural consolidations. So these are irregular lines appearing like a liver tissue hepatization that is present just below the pleura. This is called as subpleural consolidations. And this is a live video where you can see the thickened pleura, and there is a pleural consolidations with the confluent B lines. In fact, there's a more B lines with more looking like a white dot like kind of the lungs. So these kind of thickened pleura with the subpleural consolidations with confluent B lines or alveolar-interstitial syndromes with absent A lines usually suggestive of respiratory distress syndromes in the premature babies. So when also when you compare with the X-rays, when the X-rays where you can see this kind of a reticulonodular patterns with some air bronchograms. So when you put a lung ultrasonography, we can see this thickened pleura with subpleural consolidations and confluent B lines, and there is no A lines. And intermittently, we can see these small amount of white dots kind of things. These are also called as air. This is because of the air bronchograms, which appears as a white dots in the B lines. So this usually suggests of respiratory distress syndrome in the newborn. So identification of a respiratory distress in a extreme preterms or in a very preterms may not be that difficult because we have a setting, we have an X-ray. So identification of an RDS and need to differentiate from the TTN, especially in the late preterms, where both the conditions usually mimic each other. So in this kind of the late preterms and the early terms, we can use the lung ultrasonography in order to identify whether the baby is having RDS or whether the baby is having TTN, so that we can decide about the surfactant or decide about the providing of the higher pressures. The next condition most commonly is transient tachypnea of newborn, where we more commonly see in the late preterms and the term newborns. So in the transient tachypnea of newborn, usually it's because of the delayed resorption of the fluid. So the more amount of the fluid and more amount of the pulmonary edema is there, but it is just the fluid and not having any alteration of the lung parenchyma. There won't be any consolidation. So usually it presents as a alveolar-interstitial syndromes, or in a case of a very dense, where you have a complete whiteout lung, rarely present in the case of a severe TTN. Majority of the babies usually having a confluent B lines with the alveolar-interstitial syndrome and with a double lung point. So here we can see the compact B lines. So how can we differentiate severe case of a TTN from a respiratory distress syndrome is, one thing is they have a confluent B lines, both of them can have a, but they don't have a pleural lining abnormalities. So whatever the thing that happen in TTN, the pleural line will be normal, and there won't happen any subpleural consolidations or not any consolidations in the lung parenchyma. So what we can have is, we have a normal pleural line, without any thickening, no subpleural consolidations, no consolidations or hepatizations in any part of the lung. We just have a alveolar-interstitial syndromes, or we can have a whiteout kind of lung without any alteration of the pleural subpleural space. And majority of the time, there will be a double lung point. So here we can see that alveolar-interstitial, the pleura is normal. There is no subpleural consolidation. The lung other parenchyma is not having any consolidations or any atelectasis. And we can see this double lung point with a clear-cut point where the normal lung is separated from your fluid-filled lung, and the lung sliding will be present in both the areas. So this is one of the specific signs for the transient tachypnea pneumonia. So when the double lung point is present, it usually suggests of the transient tachypnea pneumonia. However, the just absence of a double lung point doesn't mean that the baby is not having transient tachypnea pneumonia. In pneumonia, where we see this kind of a consolidations, again, we have discussed where we have an irregular hepatitis liver-like tissues. They're called hepatization of the lung tissues, irregular borders, and small amount of air bronchograms are there, and there's have a pleural line abnormalities, and sometimes they also have the pleural effusion or the empymecancy. When you find this kind of picture in any preterm babies who are having respiratory distress and increased FI2 requirement even after the first dose of surfactant, if you find this kind of the babies, so there might be more of a pneumonia rather than having a respiratory distress syndrome secondary to surfactant deficiency. So in this way, we can think of adding the antibiotics and managing the babies. If you don't find this kind, we do only find a kind of subpleural consolidation with pleural thickening with some B lines, then we can think of an RDS, and the way we can, if the baby is not responding, we can give second surfactant. Here, if you find this kind of picture, then the baby is having pneumonia, then rather than giving another surfactant, we need to optimize the, we need to give the adequate antibiotic coverage for the baby, then the baby will improve. The next common complication that usually seen in the case of a respiratory distress baby is pneumothorax. So normally, as we can see, the parietal pleura and the visual pleura, there won't be any air, and there will be small amount of lubricant fluid will be there. So the parietal pleura will usually move the visual pleura. Whenever there is accumulation of air, this movement will be obstructed. That we usually will see as an absent of lung sliding sign. So in the case of a pneumothorax, what happens is we'll have this absence of a lung sliding, which is one of the pathognomic sign, and there will be B lines will be absent, and the A lines will be normal. So this is the only condition where the baby has an A lines, but you still label it as an abnormal because the lung sliding sign is absent. And we have a lung point sign, as we discussed, where the pneumothorax part will not have a lung sliding, and the normal with an A lines. And the normal lung will have a lung sliding that can have a normal A or B lines. So as we've seen this, here we can see that there is a lung sliding is happening. Here there is no lung sliding happening. There is an A lines, and here there is a B line. So this is a lung point. So absence of a pleural sliding, absence of B lines, and presence of an A lines with a lung point usually suggestive of pneumothorax. Here we can see the lung sliding is there, and there is no proper lung sliding. So this is a lung point. So when you put an M mode in this area in a normal lung, we have a seashore sign, or we can see this beach sign where you can see the small granules kind of things. When you put this M mode in over the pleura in the area of suspicion of pneumothorax, there won't be any chest wall movement, there won't be any pleural sliding, and we can see this kind of a barcode or a stratosphere sign. So here we can see this dot 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 kind of the grains like sign where you can see these lines similar to a barcode that we usually seen on the product that we buy in supermarket or in the any other markets, where this is like a parallel lines are the same. So this is called as a barcode scan. So the appearance of barcode scan is suggestive of a pneumothorax. So we're not diagnosing pneumothorax. If you suspect the baby is having respiratory distress with a differential air entry, we can do rather than asking and waiting for a lung X-ray, we do the lung ultrasonography. If you find the lung sliding sign is present, then definitely there is no pneumothorax. If the lung sliding sign is absent, then we see the B lines. If the B lines are there, then also there is no pneumothorax. If the lung sliding is not there, the B lines are not there, then we look for the lung point. If the lung point is there, then there is pneumothorax. If the lung point is not there, then we look for the lung pulse. If the lung pulse is there, then there is no pneumothorax. If the lung pulse is also not there, then the pneumothorax. So usually what we'll do is, if you for screening, we screen the babies for looking for the lung sliding and the presence of the lung sliding and the presence of the B lines and the lung point. If the lung sliding is not there, then there should be a chance of a pneumothorax. And then we need for the B lines, lung point, and the lung pulse. If everything is abnormal, then the chance for the pneumothorax is more, and where we can even attempt for a needling even without waiting for a chest X-ray. Sometimes our babies can develop pleural effusion secondary to simple respiratory syndrome, or can be secondary to the high drops, or secondary to cardiac abnormalities. So the identification of pleural effusion and the training is also important. So the pleural effusion is the fluid that usually appears as an anechoic areas. So it appears as anechoic areas between the petal and visceral pleura. So in order to identify the pleural effusion, we usually see the babies in supine position, place the probe over the posterior axillary line, where we'll create a quad sign if there is a pleural effusion. The quad sign is the area. Quad sign is the area, the anechoic area that is formed between your rib shadow, 1-2 rib shadows, and between the parietal and visual pleura. This is the quad sign. When the quad sign is present, that usually suggests a pleural effusion. Also, whenever there's a pleural effusion, if you put the probe in the costal margin, so we can see that liver has been separated from the collapsed lung. Normally, we don't see this kind of pattern. When you put this thing, the liver will be separated by the diaphragm, and there will be, and some A lines or B lines, this can be visible on here. If you are able to separately see these both things with an anechoic area, this uses a pleural effusion, and this collapsed lungs can move with the breathing, and this appears as a flapping lung tip or jellyfish sign. If you put an M mode here, then this appears as the sinusoidal sign, which is movement of this lung in the fluid. This usually present as a sinusoid sign. When these signs are present, it usually suggests the pleural effusion. In the Meconium aspiration syndrome, it is an heterogeneous disease. So different parts of the lung can have a different kind of a lung ultrasound picture based upon the presence of meconium or not there. So the pattern can vary from a consolidations with an air bronchograms to the normal areas with the pattern of B lines, with the pattern of Atelectasis. So all these kind of patterns can be seen in the case of a meconium aspiration syndrome. And these signs will changes over the time because the meconium that is present and moving will progress and will may lead to the more amount of inflammation. So the picture that may present normally initially may, as the inflammation progresses, so different kind of signs in the form of consolidations, air bronchograms, or in case of an atelectasis can happen based upon the location of your meconium and the kind of the inflammation that is causing to the baby. So in a nutshell, in a case of RDS, because affected deficiencies, usually preterm babies, you can have a ground glass opaque, ground glass shadowing with retrogranule patterns with air bronchograms. And in the case of lung ultrasound, we have seen that in the severe case, there can be white lung, or in the case of a mild moderate, we can see this pleural line abnormality of thickening, subpleural consolidations are there, the presence of B lines and presence absence of A lines are there. In the case of a TTN, because of delayed clearance of fluid, where we can see this kind of a confluent B lines, a double lung point with a normal pleural, no subpleural consolidation, and no other lung parenchymal consolidations will be seen in the case of a TTN. In this way, RDS and TTN can be differentiated. In the case of a pneumonia, where you can have pleural abnormalities in the form of breakdown, irregularities, there will be irregular consolidations with innate bronchograms can be seen. So for a RDS and TTN, the differential feature, the pleura will be normal and there is no subpleural consolidation in TTN. Whereas RDS has a pleural abnormalities with subpleural consolidations and some amount of consolidations happens in the RDS. To differentiate between the pneumonia and RDS, in the pneumonia, there happen the consolidations in the lung parenchyma with the pleural line abnormalities, where in the RDS, there will be subpleural consolidations are there, not a true consolidation that usually happens in the case of a RDS in the lung parenchyma. When you want to differentiate TTN pneumonia, especially in the case of a thumb baby, so in the case of a thumb baby, in the case of a TTN, we have a double lung point, we have alveolar-interstitial syndrome with a normal lung pleura. And there is no consolidations in the lung parenchyma in the case of a TTN, where in a pneumonia, there will be lung consolidations with pleural line abnormality. As we discussed the meconium, there are multiple findings that can just present like a pneumonia, it can present like an RDS, it can present like a normal lung also. And then atelectasis, we have a large consolidation. However, they have a clear border and they have a small amount of air bronchogram which appears as a stars in the sky. In the pneumothorax, the first and most is the lung sliding will be abnormal. There is no B lines. We can present as a pathological A lines. And there's a presence of a lung point, that is a point where you have differentiated from the pneumothoracic lung that has no lung sliding, and a normal lung where there's a lung sliding is there. So we have done, we can use the lung ultrasonography to not only for the identification of the respiratory syndrome, and there have been certain scores has been developed in order to guide us for the management of the respiratory distress syndrome with surfactant. So one of the old and famous scoring systems has been proposed by the Bratt et al. In 2015, where they have divided the lung, each lung into the three parts, the upper lung and the lower lung and the lateral lung, the both sides, and they have given the scores of around the 0, 1, 2, 3 for the different kind of the pattern. Score 0 is A pattern. Usually there is only presence of a normal A lens with normal pleura, and score 1 will be given presence of a B lens. When you have seen more 3 or more B lens, then you can label it as a score 1. And the score 2 is heavier B lens, where there is a presence and coalescent B lens are present, and there will be there may be or may not be subpleural consolidation, but these consolidations are only limited to the subpleural area. And the score of 3 is given when there is extensive consolidations are extending into the not only subpleural space and also into the lung parenchyma. So in this way, they have given the scores of 0, 1, 2, 3. 0 is normal A lens, 1 is simple B patterns with the B lens, and severe B lens with the coalescent B lens with or without subpleural consolidations, and the score 3 when there is an extensive consolidations with pleural thickening and more like a vital. So the minimum score is 0 when the entire lung is up in normal. The maximum score is 18 where you can see the extensive consolidation. They have labeled the RDS as mild. The score is 1 to 6, moderate is 7 to 12, and severe is more than 12. So these are the various scores that has been proposed by different studies. So the one of the old one is Barat et al., where they have considered the score of 4 for giving surfactant. So it has very high sensitivity but very low specificity. So in this, majority of the babies might be receiving the surfactant because of this low cutoff has been taken. However, as the specific low, we can avoid majority of the babies might be receiving more surfactant unnecessarily. We could have managed the babies with CPAP. And there have been Demanito in 2018 where they have taken is at more than 6, and Perry in 2018 where they are more than 1 equal to 5. Then Gregorio, they have taken more than 12, and Aldico 2000 more than 8, and Raminodi in 2021 they have taken as a more than 8 as a cutoff for the lung ultrasonography to be surfactant. So nowadays the meta-analysis has been done by Raminodi 2023. So and also there's multiple meta-analysis have been done. So mostly nowadays people are taking the more than 8 is a cutoff for giving the surfactant, which has a high sensitivity and specificity. Still, the debate is continuing. So, what is the exact cutoff that you can take in order to provide the surfactant, in order to provide the optimal surfactant to the babies who require, at the same time preventing the unnecessary dose of the surfactant. So, in this way, we can use the lung ultrasonography machine for various conditions aptly, timely, without having any radiation hazard. However, the lung ultrasound is not of completely advantage without any limitation. There are certain few limitations. Even though the learning is easy, but it requires the operator dependency. The person that is doing the lung ultrasound should be trained enough so that he will have a better images. So we need a proper training for the lung ultrasonography. Then only we can have a good kind of a proper images and we can interpret it properly. And as we've seen, the lung ultrasound, majority of the pictures that we've seen are, we can see only the superficial pathological pictures. So the penetration deeper is a problem with the lung ultrasonography. So deep lung pathology may not be visualized in similar to other modalities like in CT. So we may miss some deeper lung pathological conditions. Also, the use of lung ultrasonography in emphysema, pneumomediastinum, and even the diagnosis of the bronchopulmonary dysplasia is remain uncertain. There are multiple studies and research is happening to identify the lung ultrasonography in BPD and how to predict the lung ultrasonography in prediction of the BPD in the newborns. So that as multiple scores have been developed, so that is being evolved. So we still need more research to predict and diagnose the bronchopulmonary dysplasias. And in some mild cases, if the scan is not performed meticulously, we make it mild cases. So in these cases, where the lung ultrasonography might not be actually providing any major benefit to us. So we need to be used meticulously after adequate training. And for the majority of the condition, we can use the lung ultrasonography. So learning the lung ultrasonography is one of the recent need for the every neonatologist, because by using this lung ultrasonography, we can diagnose so many conditions fastly, and we can treat the conditions accurately, just like we can avoid the giving surfactant in the babies who are having a TTN kind of picture, late preterm and the early term babies, where they have this alveolar-interstitial pattern with normal pleura. And we can avoid giving second dose of surfactant in the babies who are not responding to the one dose of surfactant, where they have a pneumonia kind of pattern. And we can avoid giving surfactant in a preterm babies where they just have the pneumonia kind of pattern. Optimizing the antibiotics in these babies will actually give the better outcome rather than giving another dose of surfactant. So in this way, the lung ultrasound learning is one of the emergent needs for the neonatologist nowadays. With this, I conclude my presentation. Thank you.